Beach. And today I'm joined by a close friend and an amazing colleague, Dr. Mark Kahn. Thank you for being here today, Dr. Kahn.
You're welcome, Vivi.
So I'm going to start with a little background about you and your training, and then we'll jump into the 5 questions that I've posted, and we'll be running those questions at the bottom of our screen here. So beyond his extensive training, Dr. Mark Kahn was fellowship trained at Cornell University. I'll be posting his background later, and you can read more about his research and talents, but he is the former IVF director at the University of Washington, and now he's the medical director at the Newport Fertility Center right here, CCRM in Orange County. Thank you. So is there anything you'd like to add about your training and background? Because I would love to make sure everyone knows how awesome you are.
No, I think that was good. Thank you.
So our first question, which I think is a very critical question, people aren't as familiar with polycystic ovarian syndrome as I would love them to be, especially as I see my teenagers growing up. Can you talk about polycystic ovarian syndrome and how that affects pregnancy?
Sure. Polycystic ovarian syndrome, or PCOS, is a very common endocrine system in women. Some people think it's anywhere between 5% up to 20%, and we see it quite a bit. We basically see it every day. The diagnosis of PCOS, there's a couple different ways to diagnose this, but we use what's most commonly known as the Rotterdam criteria, and that includes 3 main things. So the first would be menstrual irregularities or no periods. Some people get irregular periods or no periods. The other would be polycystic appearing ovaries. So they almost have it almost looks like a little pearl necklace on ultrasound. You see these little circles around, you see a lot of these small resting follicles, and it's a higher number than we typically see on the ultrasound. And then the third would be signs of increased androgens. And androgens are normal hormones. They're normal male type hormones that everyone has, including women, but they're a little bit in higher doses in women with PCOS. And so you can see that on a blood test, or sometimes you can see it with some hair growth or acne or things like that.
Great. And how does that affect pregnancy and your chances of becoming fertile?
Right. So women with PCOS, because they have irregular periods, they are not always ovulating every month. And so to get pregnant, of course, you need to make an egg, and then the egg will be fertilized by the sperm. So if you're not ovulating every month, then just trying to time ovulation or trying to have a chance, you actually are getting less chances every year when you're trying to get pregnant. So we have some patients, they don't ovulate at all, so they don't even get periods, and so they're never making an egg, so there's never actually any chance for them to conceive. And then even when they do conceive, it is a little bit harder just to get everything going. There's a little bit higher miscarriage rate in PCOS as well. And so we kind of design our treatments to look at that, make that diagnosis, and then treat accordingly.
Great. I'm going to pull up the regular menstrual cycle if people can bear with me. And I would love for you to maybe explain a little bit more about what we look for in this cycle.
Sure. So in a normal menstrual cycle, you have an egg. So it really starts, a lot of people don't know this, but it starts really up in your brain and your hypothalamus and your pituitary gland. And so you start receiving signals of FSH, just to keep this simple, and that FSH will go down and it will actually act on the ovary, and FSH stands for follicle stimulating hormone. So it acts on the ovary to make the follicle grow. The follicle is like a little water balloon that contains the egg. And so as the follicle develops and the egg develops, this causes the egg to grow, and the egg actually produces estrogen. And as the estrogen increases with the growing egg, the lining of the uterus actually grows thicker in preparation of a pregnancy. And so this is how the normal menstrual cycle starts. It usually starts, in puberty, and then it continues on until your 40s, and then it's usually gone in your 50s, and that's the normal process. But if you're making an egg every month, then that egg is going to grow, it's going to pop out of the little water balloon or pop out of the follicle, and then it's going to be available for sperm to find it and create a pregnancy. If the sperm does not find it and there's no pregnancy, then that follicle turns into what's called a corpus luteum, which makes progesterone. It will involute, die off, the hormone levels will drop down, and then the lining of the uterus will shed and you'll get your period. So that's how the normal menstrual cycle works. And in PCOS, what happens is PCOS patients really don't make a lot of eggs all the time. Occasionally they will make an egg. Sometimes with medications like metformin, they can make more eggs and get regular cycles. Sometimes with weight loss, if they happen to be overweight, that will help as well. But we also have medications like Clomid or Letrozole to help make eggs so that the whole process can get started.
Can I ask you, so the delicate balance of the hormones really relies on having a healthy body, because our body changes. We have very efficient system, so we won't use our fats in our cells in our body to make hormones when we need them for other functions. So when we have a patient who's maybe anorexic or not eating well, they also might have some hormonal imbalance. Is that correct?
Yes, absolutely. So what's been shown is that women on either end of the weight spectrum, whether it's overweight or whether it's underweight, they do have a harder time getting pregnant. And in the case that you just mentioned, that's actually quite common, and especially in some younger women or teenagers, where they might have eating disorders, or they might exercise a lot or even too much, and then they actually lose their periods. And so that actually is even more dangerous for them, because they may not realize when that happens, their bodies are not making that normal estrogen that it's making every month, and they can actually be at risk for bone fractures and things like that. And so that is a very common thing that you'll see sometimes in high school girls or young women, and it's important to know that can be dangerous for them.
And something I see regularly is that we have patients who have PCOS and don't know it. Is that something you see in your practice? They come to you and they're not getting pregnant, and you're like, oh, well, this is your diagnosis.
Yeah, we make that diagnosis almost on a daily basis around here. So it is quite common. And if someone's having some of those signs or symptoms, they can come in to be seen. And most general OBGYNs can make that diagnosis as well. But the typical way is to do an exam, do an ultrasound, do some blood work. And usually we can make that diagnosis pretty quickly with PCOS, but we actually see it quite a bit. A lot of the PCOS patients are overweight. And so it has been shown that even just simple weight loss techniques will be very effective in helping them get pregnant and even sometimes normalizing their periods again.
Great. So these are all things that I bring up as a primary care doctor that I see and I don't think the public is aware of. So that's why I love having specialists like you here. I'm not happy to hear that you're diagnosing it every day, but I think it's important that the public knows that this is a very prevalent problem. And thank you for going through the cycle. I do have a lot of teens and parents who want to get hormone testing when we do their annual test, and I have to tell them you have to wait till day 3 after you ovulate. Is that correct? You want to speak about hormone testing?
It depends which hormones you're testing, but if you're looking at the reproductive hormones and you want to check to see if their ovarian reserve is good, so we do that testing here on a daily basis as well. Then we do a blood test on day 3 for the FSH, follicle stimulating hormone, and also estradiol. And what that will do is it'll show us how their ovarian reserve is for that cycle. Now, if they don't get periods, of course, you can't do it on day 3, you just check it. But that level of FSH can fluctuate throughout a normal menstrual cycle. So you want to try and check it at the baseline. So day 3 is a good time to check it. We usually do day 2, 3, or 4. And if that number, say your FSH level is less than 10, for example, your estradiol is less than 80 or 100, then that would show that you have normal ovarian reserve. So what happens is, for example, if you go into menopause, then your ovary kind of burns out. It doesn't make eggs or estrogen anymore. So it kind of sends a signal back up to your brain and your pituitary gland, says, hey, we don't see any estrogen anymore. Give us more FSH. So your body starts making more FSH. And so that's why in menopause, you actually see FSH levels that are very high, like 40, 50, 100 we see sometimes. And so we also use that information when we're looking at fertility because, for example, if occasionally we'll have someone in their 20s or 30s with a really high FSH, and unfortunately for them, their ovaries have stopped functioning at a younger age, and we do see that once in a while as well.
This is great information. Thank you. Even, I have some colleagues who love watching this show, and I always have to listen afterwards because I'm typing in your answers. There is a great question here, and I'm hopeful that there's a good answer. Can a woman, once diagnosed with polycystic ovarian syndrome, be rid of it, cure herself, and no longer have this problem? Or is it something you always have?
Yeah, well, I think that's a difficult question. So when we look at PCOS, we kind of look at it on a scale, and we see a lot of, you could have a 1 out of 10 or you could have a 10 out of 10 with PCOS. As you get older, you start to see less and less effects of the PCOS because your ovarian reserve starts to decrease naturally anyway. But I would say that when we help someone with maybe a lower level PCOS get pregnant, there is actually a very good chance that they might be able to get pregnant again on their own afterwards. And we see that across the board with not just PCOS, but fertility patients in general, is that if we can get that first pregnancy going, a lot of times they can get pregnant again on their own or with very little treatment the next time, as long as it was something simple to take care of. But the good news here, Vivi, is that PCOS is actually one of the easier things that we deal with. And so, a lot of times we'll get some blood work, we'll help them lose a little bit of weight, we'll start metformin possibly, and then we do simple Clomid or letrozole cycles and help them induce ovulation. And if everything else is working, like with the sperm and the tubes, then they get pregnant pretty quickly.
Okay, great. Thanks. We're going to go on to our next question. How can you maximize your odds of getting pregnant? And for those of you who don't know, I'm not very private, but Mark's a good friend of mine before I ever needed to call on him for help for friends or myself. But he was very encouraging when I was in the older age bracket and said, go ahead and try natural. And I said, why would I try naturally? I froze stuff when I was younger. And I am so grateful for that advice. And I would love to hear what you would say to people who want to try naturally. How do they maximize their odds before they come to you?
Sure. I think there's definitely ways we can do that. In general, kind of the when it's time to see a specialist or talk to a specialist, if someone's under 35 years old on the female side, and they've been trying for more than a year, that's a good time to go ahead and come in and at least do some basic testing. If you're over 35, that would be at 6 months. So that's kind of a good time frame, just ballpark time frame to say, hey, let's kind of check things out. And the reason for that is that the most common problem that we see, or the most common situation that we see, is advanced maternal age. And as you know, the eggs, as they get older, they're harder to fertilize. Everyone has a certain time limit of their own eggs. And so normal fertility happens in your teens and 20s. It starts to decline in your mid 30s, and it's usually gone in your early 40s. And then you lose your periods in your early 50s. And that's the normal, just, mother nature. And so before we, talk about what can they do to improve their chances, just know that it's always good to get checked out and just do the basic tests early. Check the sperm, check the tubes, check the eggs, do an ultrasound. Those are very easy things to do. And there's a whole group of things we actually do before you get pregnant called preconception counseling. So is it even safe to get pregnant? So for those things we check to make sure you're immune to German measles, chicken pox. We do something called genetic carrier screening, which you can actually do a saliva test now with your partner and look for over 275 genetic conditions like cystic fibrosis. We do all that before you even start to get pregnant. And so that's why it's reasonable to come in and see someone before you even get started, just to get those things checked off the list and then get started for your actual attempts.
I'm really grateful in my seat getting information from what people do when they see a fertility specialist, when they do those high-end tests, because we sometimes have a baby with some endocrine issues in the newborn period, and I can look for the more common ones and say, oh, we ruled out that. The California State Screen has a delay, and I'm very active calling them and saying, oh, we have a baby in the NICU who's not doing well. Can you please get me the results? But there's still that delay. But we can easily say, for the genetic diseases that have a very low incidence of spontaneous genetic defect, they're usually inherited. I can say, oh, there's no way they got it from mom or dad. And it's so nice to have that, which hopefully I'm going to have Dr. Zadeh on the show, and she'll talk
Oh,
about
good. Yeah, she's
the pros
excellent.
and cons.
Yeah, we
Yeah.
offer that genetic carrier screening to every patient. It's part of our new patient forum because we want to give them the option to check. It's one more way to reduce the problem with the baby. And now that the testing is so good, you've got these companies doing from a saliva sample over 200. I heard there's one coming out. It's going to be like 800 pretty soon. I mean, these are conditions that in the past, even to do one cystic fibrosis test used to cost $1,000. So now they're so inexpensive, and a lot of them are covered by insurance, that it's kind of a no-brainer. And we have had patients that didn't know it. And one of the reasons that some patients come see us now is because they have a baby with a problem. And had they had this testing before that, they would have identified that. We can actually test the embryos for that problem ahead of time if we know about it ahead of time.
Yeah, it's a very interesting day and age that we're at, and there's some ethical issues that I'm really grateful that people like you actually think about a little bit more in depth for the implications of testing. But you guys have been great at guiding the public up when it is worthwhile to do. So let's move. Great concepts. When I was asking the question about maximizing your ability to get pregnant, I was jumping to like the simple things like balance, stress. But what you're saying is so much more true and going to be so much more high yield. But I do want to say that when I was struggling with my second, that was IVF, I think when I finally let go and enjoyed my family, because it's such a process when you do IVF, the natural hormones of being with my family and cuddling with my son and relaxing and saying, if it happens, it happens, was so liberating and really helped probably the fertilization process proceed. That's my perception. That's nothing scientific, but I
think that's accurate. And going back to that question, there are a lot of things you can do once you get in that mindset that you want to try to get pregnant. So just as an example, you would start prenatal vitamins. That's a very easy, common thing to do. You would try to eat a very healthy diet. So obviously you avoid processed foods and things like that. If your body mass index is high, you would try to lose weight with some simple weight loss techniques. Also on the male side, you would avoid heat because like hot tubs and things like that can reduce sperm counts. Any smoking would not be good. On the male side, some guys use these testosterone supplements for bodybuilding. Those things really decrease sperm count. So we don't recommend hormones or things like that. But those are and then of course, stress reduction and healthy living, all those things are very effective in getting you ready for that, pregnancy planning.
I do want to, I don't want to hold us up, but you're bringing up these great questions that I think come up for the public. I don't even think we talk a lot in our groups and when moms get together saying, oh, we really want our friend to get pregnant. We don't talk about the male contribution to infertility. And I've heard you talk about it quite a bit. Is that something, when someone comes to you with problems, how often is it male versus female?
It's almost equal. Yeah. I mean,
wow.
So, kind of look at it in, part female, part male, and then part either undetermined or both female and male. So we see it quite a bit. And that's only been, if you look at, the history of the modern world, unfortunately, that's on the rise. And a lot of people, guess why that might be. But I think there is probably some evidence that it's environmental in nature and some of the chemicals and things that are going on. But we see that quite a bit, actually. So a lot of times we don't like to put a label on, is it just male or just female? And you'd be surprised. I'd say most cases we have a little bit of male and female going on.
Okay. Gosh, these are such great pearls. Okay. We're going to move on. What should they know before they seek IVF help? And that might actually, let's see, is it showing up? That might actually mean, what are they going to, am I showing it? I think that might, to me, when I hear that question, what does the process entail? How intense is it? For me, I was so glad you told me to try naturally only when I did the second one through IVF, because it is a process. It is not that fun. It's not terrible. It's only it's not that much of your life, but the stress. So can you maybe allude to that portion, and then also how you would answer that question yourself?
Sure. So, I think the best thing people can do before they go into IVF is just get a little bit of information and education about the process. And there's a lot of good stuff out there. We're actually in the process of making some videos and things to post
Great.
on our website and YouTube. But I think that, when I do a consult with a patient here in the office, you have the slides that I sent you. These slides, we kind of go through each slide and each step and go through the whole process. So first, we do the basic tests, then we start medication, grow the eggs for 2 weeks. We kind of just give them all those, kind of show pictures of how it works and that kind of thing. And I think when someone has the information and education, the process goes much more smoothly for them. And I think that they will often do a lot better and have less stress. Because I do agree, when people get stressed, I mean, we understand takes a little bit of time, a little bit of effort. There's a financial component. So people get a little bit, have a little bit of anxiety sometimes. But the more information they have, I have some patients that, they just kind of have the right attitude. They understand everything. They've been educated. They just go through like no problem. And they're like, okay, let's go get them. Okay, I know, we're going to get the eggs now. And they actually know the next step. So I think just being prepared is probably the best thing, and getting that information.
And I think in our world, there's a lot of multiple hats that women wear, where they're supposed to be succeeding in their businesses and being the nurturing. They have to have the social circle, they have to have the business, they have to then slow down to have the child. I think really slowing down and realizing what's at stake if you don't slow down is paramount for women now in this day. So I think having friends who've gone through it, who can tell you, slow down, you don't want to lose an embryo, that's just going to be, for someone like me, that's really important to have somebody tell you again and again.
You bring up a very important point, Vivi, and that is that, I see people every day that could, probably do whatever they want in life or have whatever they want in life. They have all the resources in the world, but these people still cannot get their younger eggs back. And so their only options are to, really try with the last few eggs that they have, or go to donor eggs, which is the next step in the process. And so that's probably the most important thing for people to know out there, is that there is a time constraint on the natural egg's ability to create an embryo. And so we have people say, should I freeze my eggs? And the answer to that for me is very easy. You should yes to everyone at the earliest age that you can, basically. But unfortunately, when you're 20-year-olds, the last thing you're thinking about is freezing your eggs. They have other things on your mind. It's not until women typically come in their mid to late 30s, sometimes in their 40s, that they are looking at that. And so I think there is an awareness that's improved nowadays compared to the past, because we are seeing some women in their early 30s now coming in for egg freezing, but by far and away, usually it's women in their late 30s or early 40s.
And I know my generation is speaking to the younger generation and saying, freeze them now. Once you hit 20, just freeze them. It's really not that expensive. I see my friends living in these rentals by the beach, and they might be single and not be putting their money towards the fertility, and they'll complain about how expensive it is. And I just think, oh my God, one day they're going to look back and say, why didn't I?
So, these patients, they can afford anything in the world, but they can't buy their eggs back from 20 years ago. So, I mean, that's just what we see. And so I think that, I think having that awareness is good. And you may not ever use those eggs if they're frozen. Maybe a few years later you find someone and you get pregnant, but it's kind of like insurance. We all have insurance, but none of us wants to get in a car crash. So I think that it's kind of the same thing in a sense.
Mm-hmm. So that brings us to a very common question, and one that is changing all the time with science. How old is too old to freeze embryos or eggs? Is there a too old? Will you, Dr. Khan, try any age? Or do you know what age is healthy and not healthy? Why don't you answer that?
Sure, I can go over that. Well, if you have that slide that shows the chromosomal abnormality rate, that's even more helpful. But basically, there's no magic answer to that. The bottom line is that there is a linear and then eventually almost exponential decline in the ability of an egg based on age to create a normal pregnancy. And so I can tell you what we typically see, and I can give you rough estimates for different age groups. But I would say that the eggs are really designed to be used in your 20s and maybe into your 30s a little bit. They're not really designed, so to speak, to be used much after that, because you see much higher rates of aneuploidy, miscarriage, Down syndrome, things like that. And so I would say that we've seen pregnancies here with eggs we've probably had, we've done thousands of IVF cycles. I've been doing this for 20 years. I would say that in our practice here, we've got maybe 3 or 4 at 44 and 45. I think we've got 1 at 46 over, thousands of cycles. And so when you ask, well, can a 42-year-old freeze their egg? Sure, a 42-year-old can freeze their egg, but they're not going to have any better chance than if they were trying to get pregnant with IVF at that same time. And so the problem with the egg freezing in a situation like that, or even just it's not a problem, but it's one of the realities of egg freezing, is you don't know how the eggs are going to do until you thaw the eggs and put the sperm in to fertilize the eggs. And that may not happen right away. So unfortunately, it's not a guarantee, but it's an extra chance at creating a pregnancy that you would not have had otherwise. And as we all know, we have many egg freezing babies, so it definitely can work. But really, there's not a magic age. We'll do it up, so, I have some patients, right now currently trying to use their own eggs in their high 40s. And they know we don't cut people off, but in general, we don't really suggest it or recommend it probably over 43. I think that's a very common, 42, 43, somewhere in that ballpark. But we have people that just want to try once. They don't want to do egg donors. They don't want to do that. And so we do it and we let them try.
Okay. 2 questions came up. But I want to clarify 2 things. You said you had a 46-year-old. That was not through freezing eggs, but
that was just IVF, yeah, regular IVF with their own eggs. Egg freezing, I don't think we've had someone in that age group, but we haven't. I don't think I've frozen anyone's eggs at 46 before. Probably, most people over 40 will still offer it to them, but they'll have a much lower chance of just using those eggs just like they would anyway if they were trying to get pregnant. We'll do it. I try not to do it over 42, to be honest. Even over 40, I make sure they know that there's a possibility it's not going to work. And, that it's hard because I don't want to be overly negative, but I don't want to give them a false sense of hope either for these eggs, because at some point they're going to thaw those eggs and try to fertilize them. And there's a chance that they may not make a good embryo or a healthy embryo at that point.
So what people listening need to know, the difference between freezing eggs and going straight into an IVF cycle, is that you don't have a freeze-thaw process. So when you're saying that people at the same time have a partner and they're going to go ahead and transfer embryo, that would be all at once, versus freezing is when you put them away for later use.
Yeah. So do you have the picture? If you have the picture of the eggs and the embryos, I can show that to you. But basically, with an egg freezing cycle, we would collect the eggs and freeze them right away. Okay. With an IVF cycle, that's a normal IVF cycle, we would we would collect the eggs, and then we'd put the sperm in them while they're still fresh right away and create the embryo. And then later we may freeze the embryo, but that's different than egg freezing. So it is important to know that embryo freezing has been around a lot longer. It's always thought to be a little more successful. It's tried and true. So embryos do actually freeze quite well. Sperm freezes quite well and thaws quite well. Eggs are more like water balloons. They're larger and there's a lot of sensitive organelles inside, and the egg actually creates the embryo. And so because of that, it is a little bit harder to freeze and thaw eggs. We can still do it, and they have developed some very good techniques to do it now, but it's not quite as the same as freezing an embryo.
Okay, thanks for making that distinction. Someone wants to know the average price for freezing eggs, because in her 20s, that was her biggest deterrent. I think pricing is all all over the place, depending on what type of clinic you want to go
I
to.
mean, we're happy to send some estimates when people come in. It really depends what they're doing, but from a rough ballpark perspective, it depends. Everyone's different because everyone needs a different amount of medications. The medications might be, a few $1,000s depending on how much they need and what their ovaries look like. And then the cycle itself. I mean, I don't want to give, in case I actually don't know the exact numbers, but we're happy to give those estimates. But it's, egg freezing is probably the least expensive out of all the IVF cycles that we do, because you're not doing the fertilization, you're not doing the culture of the embryos, you're not doing the chromosome screening of the embryos or the biopsy, and you're not doing the transfer. So it's going to be, out of the big picture, it'll be probably the least. So I don't want to quote numbers in case I'm wrong.
But it is easy to call clinics and ask for an estimate.
Absolutely. Call the, and when you do,
I'm sure you could Google that too.
Yeah. But when you do call the clinic, you have to be comparing apples to apples. So here are the components of an egg freezing cycle. There's the initial visit, there's the medications, there's the clinic fees, or what we call professional fees, for the doctor in the clinic to do the ultrasounds, draw your blood tests, monitor you during that process. There's the egg retrieval, which is usually in an outpatient surgery center. We have our own center here upstairs. There's the anesthesia, and then there's the processing of the eggs and freezing the eggs. Usually most places will have that all kind of wrapped up into one package price, so it's kind of easy to understand that. But if you call one clinic here, one clinic there, you make sure that you're comparing apples to apples, because some places will give you this unreasonably low number and say, oh, but then they add in all these things at the end. So you just want to double check. But in most places, probably about the same cost at most centers, I would imagine.
And understanding the language is extremely important when you're talking to your doctor. And if you don't understand, because I sometimes flip some of my terminology, and that makes for confusing conversation. So you really have to know what you're talking about, or what your doctor's talking about. So if you don't know, do stop them and ask them. Okay, so that's very helpful. I'm going to go to our last question, unless there's something else you want to say about how old is too. Oh, I do have one question. If you said if you're not going to totally stop someone, so someone's 49, been living very healthy, and they want to try, and they will spend all their money, will you let them try?
Well, we would do everything we can to, so first we would do testing. So we always do that on everyone. We would check their AMH, FSH, estradiol, antral follicle count, sperm, all the normal testing. If their numbers showed that they might be able to make a decent number of eggs and have a chance, then I would say, yeah, I'm happy to give you a chance. But in general, it's not really recommended for someone like that. I mean, it's really just, I think that some people, they've got to try once just for closure, but we would really try to discourage someone like that. And actually at 49, they only have about 1 year to do donor egg. I would really try to encourage them to do donor egg at that point. So we'll do that up to age 50 or 51 typically.
So when you say donor egg, that means transplant somebody else's egg with your partner's sperm.
Right. So when it's, let's say that someone comes in, they're 43, and we try to make eggs for them, and we try to do IVF 3 times, and they just can't make any good embryos because unfortunately the eggs are too old. The next step is typically an egg donor cycle. And the way that works is that they actually find an egg donor. It's usually an anonymous situation. So they find an anonymous donor through a profile, through an agency. And then we would run the IVF cycle on the egg donor. And then the recipient just gets the eggs, and the rest is, and so it's the husband's sperm, it's the donor's eggs. And then we make the embryo, and then we give the recipient, the female patient, back the embryo. And so she carries the baby, she grows the baby, delivers the baby, breastfeeds, all that. And so that's a very common way to do it over 42, or if someone just doesn't make a lot of good eggs anymore.
It's still a beautiful option, just because carrying that baby really is a bonding experience in itself. So did you want to say something else?
Oh yeah, I would just say that, we've done a lot of donor eggs cycles over 20 years, and we've never had a recipient come back and say, oh, I regret doing that. It just like you said, it's exactly that. It's a bonding experience, and they feel like, especially even after trying harder because a lot of those patients have done IVF 3 times or something. They're just so appreciative and they're so happy. And then they have extra embryos for more pregnancies too. So it's usually a very good experience.
Yeah, I can't tell you how strong the bond is in adoptive families, and we're not even talking about carrying that baby in your to term. So I've always thought of adoption as an option for me, and it's something that not everyone's thought of or considered, and they need some time to think about. But I would hope that people would feel strongly about donor eggs. That's a really beautiful thing we can do. So a great question that every physician, every doctor's getting from friends who are pregnant. I have a ton of pregnant expecting moms in my practice, and I really want them to get the vaccine, but I don't want to push anybody because I don't, especially during an IVF, if they're doing an IVF cycle and it's stressful.
Yeah.
But what do you want to say about COVID-19 and vaccine and protection?
Well, this is a question we get pretty much every day now. And, we really try to stick to the facts and just look at that. There's a lot of noise out there about COVID and the vaccines, but, the facts would suggest that the current recommendations based on all the professional societies, so the current, if you look at ACOG and ASRM and CDC and all these people, they say that, and I think I agree with most of what they say, is that it makes sense to get the vaccine before you get pregnant, if you can. So you'd be immunized before you get pregnant. And that's because there's no safety data on the vaccine during pregnancy. However, I will say this, is that it's not such a simple thing to say, oh, I'm not going to get the vaccine during pregnancy, because for a couple of reasons. Number one is that women that are pregnant, if they get COVID-19, they will have a much higher chance for severe disease or death. In some studies, over 10 times the rate of severe disease or dying. And so that's a pretty significant difference between someone of the same age, whether they're pregnant or not. So that's the first thing. The second thing is that probably over 60,000 women have had the vaccine during pregnancy that we know of, and we have not seen anything, or there's really no reported cases of problems at this point in time. So that's a very good bit of information to kind of think about. The third thing is that the women that have had the vaccine, especially closer to the 3rd trimester, have shown to pass on antibodies to the baby, to the newborn. And so that's a promising thing that may confer some immunity to the baby in itself. So what I would say is that, the other important thing is, if you do are thinking about this, there is a registry called VSafe, V like Vivi, VSafe.
Get back at it.
And that's a very good, I encourage anyone who is pregnant or has received the vaccine to go and register with that, because they're keeping data on all the pregnant women that have been vaccinated. And so, that's a lot of people that have received it already. But unfortunately, there's no long-term safety data, but there's no long-term safety data in non-pregnant people either. And yet we all got the vaccine as well. I think that for what we do in our practice, we recommend it before they get pregnant if they can. Oh, and I want to address this rumor about the vaccine causing infertility. So there's
so much out there.
Crazy rumor out there about that I've heard about from a few people. I was like, where did that come from? So I tried to look it up and figure out where it came from. And it looks like there was some guy that said that the placental, I don't know, that the vaccine might interfere with the placental receptors and this and that, but there's no science or data to support any of that. And there's no evidence that caused any problems. So I just want to say that that's completely false. At this point in time, there's no data to support that, and that you should get vaccinated if you want to get vaccinated and have a chance to reduce your rate of 99% from severe COVID. So, but then the other thing that I was saying is that we recommend them to get the vaccine beforehand if they can. And now people are getting invited to do the vaccine almost on a regular basis now for anybody. So a lot of people are getting the vaccine. And then the question is, do you get it if you are already pregnant? And that's a personal decision. So we cannot officially recommend that because there's no safety data. However, all the organizations say it should be made available. And I would say, just because all the people that got the vaccine early that were pregnant were doctors and nurses and healthcare workers and we saw them here as patients. And I would say that I was interested to just kind of see how many got it when they're pregnant. I would say about 2/3 of them received the vaccine, just made it the decision on themselves to get the vaccine out of the healthcare workers that I saw as patients. And I thought that was a pretty good number. So.
But Dr. Khan, I might have misunderstood you. I have seen data from VSafe on pregnancies completed successfully after the vaccine. So there are, I think, tens of thousands of data points of pregnant women vaccinated. Is unless I misread
Oh,
what
yeah,
I was.
there's over 70,000 registered on VSafe. I don't know if they've all completed their pregnancies, but they're
I
following
just
up.
heard you say that we don't have data on the pregnant on.
Well, we don't
pregnant.
have long-term data on
Not the long
the
term.
babies, on their development, on those kind of things is what I was trying to say. But all the current, you're correct. All the current data on vaccines and pregnancies have shown no problems at this point in time, or no really unusual findings compared to, other types of vaccines and things.
Okay, great. Any final comments? I want everyone to know that they can find you at newportfertility.com. And I would love if there's any high yield comments or tips. I think ending on the COVID-19 question is wonderful. But if you want to add anything more, any question I didn't hit on that you've seen in your office.
No, I think, first of all, thank you for having me, Vivi. I really enjoy your show. So I see this as a big thing in your future. I think you're going to be national someday, international someday.
Thanks to you being on my show.
I think that from a fertility perspective, I think that the easiest thing to do is if you're thinking about getting pregnant, or you're thinking about trying to get pregnant, or even you've been trying to get pregnant, it doesn't hurt to get checked out, number one. It doesn't hurt to even you'd be surprised. I have patients here that have been trying for 4 years, and then they come in and they're like, oh, I didn't think about check my varicella immunity or my genetic carrier screening or things like that. Mm-hmm. Just go in and get checked out for all the basic stuff first. And then you can do treatment if you want to do treatment. That's totally elective. It's up to you. You don't have to do treatment. So I think that that's probably what I would suggest for most people. And then if you have the option to freeze eggs, if you're younger, if you're, planning on maybe postponing your fertility, then, really consider it, because that's something that a lot of people unfortunately don't think of until it's much later in life.
Great. Well, I hope everyone appreciates how much luck we've had to have you on the show. Your name is so pervasive in the medical community of doctors who've had to use IVF. I felt famous for knowing you when I was in circles of people talking, oh no, he's my good friend. So we are so lucky to have your wise words, and I look forward to seeing what other questions pop up. I'll shoot you a text if there's anything that I think I need your help answering. But have
I'd be happy to do it.
Friday. Go get that surf. Are you going to surf this weekend?
I don't know. We'll see.
He's an amazing surfer, for those who don't know. All right. I'll talk to you later. Thanks again.
All right. Thanks, Vivi.
Bye-bye.
Take care.